as I've just said before, this algorithm is specified for those patients complaining of low back pain for more than 3 months with an age of onset that's below 45 years. Now, this algorithm is designed around three major ideas that are going to aid us to reach the definitive diagnosis. The first one is the definite radiographic sacroiliitis. The second one is the presence of some spondyloarthritis features. And the third one is the presence of HLA-B27. And the last one is the MRI. Now, before delving more into further details about each of these entities, I guess we need to understand the basic idea behind each stone. Now, this definite radiographic sacroiliitis is basically you do a radiograph with the patient, and this radiograph shows a sacroiliitis, an inflammation at the sacroiliac joint. Now, with regard to the second stone we have is the presence of spondyloarthritis features. Now, these spondyloarthritis features, I have divided them into four major chunks. The first chunk is positive family history for axial spondyloarthritis, inflammatory back pain, and alternating buttock pain. And as you can see here from this first chunk, it's signs that somehow frankly associated with the disease, with spondyloarthritis. Either you have a family history of that axial spondyloarthritis, or you are coming to my clinic complaining directly of having an inflammatory back pain, or you have an alternating buttock pain. Things that related to the term spondyloarthritis, inflammation in the vertebral column and sacroiliac joint. Now, the second chunk here we have is basically describing some of the further characteristics for these for this entity, this spondyloarthritis entity. The first one we have is enthesitis. Now, enthesitis is an inflammation in the enthus. What's enthus? Because we know itis. This is an inflammation. Now, enthus, if we imagine that we have a certain bone here, and we have here a muscle, and this muscle is trying to attach to this point here. Now, this site of attachment of a muscle, in fact, this is going to be the tendon of that muscle, or a ligament, or even a joint capsule. You know, imagine as we have a joint here. This is another bone that's trying to articulate with the previous one. We have this is a joint capsule. Now, the site of attachment of this joint capsule to the bone, if this site here gets inflamed, this is known as enthesitis. Now, the common enthesitis associated with spondyloarthritis is plantar fasciitis, and this plantar fasciitis usually comes in a form of heel pain. Now, this also could occur at the site of the calcaneal insertion of the tendon, of one of the tendons, the posterior tibial tendon. Now, other features like uveitis, particularly anterior uveitis, which represents one of the major extra-articular manifestations for this entity, spondyloarthritis. Also, dactylitis could be considered one of the features you're looking for. Now, the third chunk here is the inflammatory bowel disease, psoriasis, and asymmetric arthritis. For the first two, inflammatory bowel disease and psoriasis, these are diseases that are associated with spondyloarthritis. And for the last one, asymmetric arthritis, this is in fact a description for the joint affection in this entity, spondyloarthritis, because spondyloarthritis usually comes in a form of oligo-asymmetric affection. Now, the last test we have here is, the last group we have here is the one that deals with positive response to NSAIDs. Why specifically NSAIDs? Because, you know, the first line of treatment for those patients is to give them an NSAIDs and, you know, do a watchful waiting. And what I mean by watchful waiting is that you give your patient a certain drug and you tell him, I'm going to watch you for the next month and to see whether this drug is in fact working or not. And if this drug is working, then this is a favorable feature that in fact should direct you thinking towards spondyloarthritis. Now, other laboratory features like elevated ESR and CRP level are also suggestive of spondyloarthritis. Now, that was the second stone we have. The third stone is HLA-B27, and what's quite interesting about this HLA-B27 is that this is a supportive. What I mean by supportive, you're writing this test here with this, you know, a very unique specific number that gives you that feeling of, you know, specificity, diagnostic power, and so on. But you come to say that this is only a supportive. Yeah. According to research, this test here, this laboratory test, is not diagnostic. Now, the question is why this test is not diagnostic. Because briefly, normal individuals who are happy and doing their normal activities and they're, you know, quite enthusiastic about their life, may have this HLA-B27 in their serum, in their blood. And if you rely solely on that test to sort people into patients with spondyloarthritis and normal people, you're gonna have a lot of normal people like me and you in that entity. You're gonna have normal people diagnosed with pathology they do not have. So the right way to deal with HLA-B27 is to consider this test a supportive. What I mean by supportive here is that you have to look for other features to say that this patient has spondyloarthritis. Now that was the third stone, in fact. With regard to the fourth stone is the MRI, magnetic resonance imaging. And magnetic resonance imaging is a way much superior to radiographs and X-rays in this kind of disease. It's highly recommended to start doing an MRI for patients, for suspected patients with MRI, as soon as you make the diagnosis, particularly if it was within the early period and not after 2 years. Now, after knowing all these major ideas, we're going to try to connect these ideas in a way that makes sense to reach a firm diagnosis for this patient. Okay, the first, so we have 4 stones: the definite radiographic sacroiliitis. We have the spondyloarthritis features with the 4 major chunks, the presence of family history of spondyloarthritis, inflammatory back pain, robotic pain, the 4th enthesitis, which is quite remarkable for this disease here, dactylitis, uveitis, the extra-articular manifestations, the other 2 major diseases associated with spondyloarthritis, and the kind of joint affection, the treatment results, and the laboratory results. The HLA-B27 and the MRI. We're going to start with doing the definite radiographic sacroiliitis. If the radiograph show a frank sacroiliitis, and this patient is diagnosed forward with ankylosing spondylitis, you don't need to do anything else. If the radiograph shows no sacroiliitis, then start looking for the spondyloarthritis features we have discussed before. Now, these features, in fact, these are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. These are 11 features. If you find 4 or more of these 11 features and you have an associated compelling clinical picture, and what I mean by compelling clinical picture, you have a certain clinical picture, a picture that with your own experience you can say that this patient is likely to have spondyloarthritis. So if you have 4 or more joint affection and you have that unique compelling feature, then you can go for an axial spondyloarthritis diagnosis directly. If you lack that feature, if you lack that clinical picture, then go for the HLA-B27 to see the results. If it's positive, then go for it. Then this is an axial spondyloarthritis. Since we have here a joint affection more than spondyloarthritis, we have more than spondyloarthritis features, and we have this supportive. So by combining these 2 together, we have the supportive test, and we have the clinical feature. We have, in fact, 4 more features, and we can say that this patient is suffering from axial spondyloarthritis. If the HLA-B27 is negative, then doing an MRI is going to be very useful in these situations. Now, what if you don't have 4 or more features and you just stuck there with 2 or 3 spondyloarthritis? These are usually an oligo. You have an oligo affection, oligoarthritis. The next step, because we finished the first, the second, and here the third step is going to be the HLA-B27. We're going to do the HLA-B27. If this is positive, and we have an associated compelling clinical picture, then this is going to be an axial spondyloarthritis patient. And if we lack this clinical picture, we're going to move to the MRI. Now, as you can guess, that there is a quite difference between having an oligo affection and having a poly affection. With the poly affection, we move the clinical compelling picture from being second to the HLA-B27 to being first. Just directly after diagnosing your patient with polys, you move the compelling clinical picture to see whether the joints, to see whether the clinical picture is favorable or not. But here with the oligo, this compelling clinical picture is moving downward in the diagnosis hierarchy, and HLA-B27 is moving upwards. Okay, I hope this point is quite clear for you. Now, what if the HLA-B27 is negative? If the HLA-B27 is negative, we're going to move directly to the MRI. Okay, finally, if you have just 1 joint that's affected, you have a posteoarthritis. If that posteoarthritis you have or even you don't have any features, any of the previous features, you still need to go for the HLA-B27. If this HLA-B27 is positive, then go for the fourth stone we have, the MRI. If it's negative, then it's negative. The HLA-B27 is negative, so you don't have that supportive feature with you, and you're also lacking the oligo feature, because we said one of the features here is oligo asymmetric. You're lacking the oligo, and you're just stuck there with either no joint affection or one joint affection. So you have no wide joint affection, and you have no supportive features. So you have to reconsider other diagnoses for your patient. So after talking about this algorithm here, we have reached that our patient could be an ankylosing spondylitis from just a definite radiographic sacroiliitis, or he can be an axial spondyloarthritis if he presents to you with polys, or after HLA-B27 positivity, also for a poly patient, or with if the patient comes with an oligo feature and you do the HLA-B27 and he's positive and the competitive linker picture are also there, then your patient is probably having an axial spondyloarthritis. So, but what about those who were left for the MRI to take the final destination, to determine the destiny? This one here, this one there, this one here, and I guess this one also here. Now the MRI.
علاء عشان بس بقيه الزملاء ياخدوا بالهم. Why ankylosing spondylitis is excluded from our case?
It's excluded because the joint affection ما كانش كان جاي في unilateral، كان جاي asymmetric، وكان في atypical spondylitis.
تمام، هو ده اللي احنا عايزين نتكلم فيه، ان احنا key points عشان الزملاء ياخدوا بالهم. فيبقى انت excluded عشان ايه؟ قولي تاني كده.
عشان في asymmetrical affection، وكان في atypical syndesmoid myophytes، وما كانش فيه الفيتشرز الفرانك فيتشرز بتاعت الفلاتند lumbar lordosis والاكزاجريتد thoracic kyphosis والهايبر اكستندد نيك ما كانتش موجوده، والاكس راي ما بينش ان في سكليروزز موجود على الساكرويلياك جوينت، ما كانش فيه البامبو سباين موجود.
So ankylosing spondylitis is one of the differential of the previous case. صح كده؟
بالظبط.
طيب عايزين نشوف بقيه الديفرنشال.
هنشوف احيانا كده لو عملنا كده بالظبط هنلاقي كل الديفرنشالز. طيب
واضحه لبقيه الزملاء why ankylosing spondylitis is excluded. طب كمل يا علاء.
طالما مش بيوضح.
لا في حد تاني يشارك معاك عشان كله يشارك.
والله دكتور هو احنا قسمنا يعني هو ده كان التاسك بتاعي ان انا امسك شرح الموضوع، يعني كل واحد كان عمل.
كمل عليه. يبقى احنا كده الانكلوزنج سبوندلايتس excluded. يبقى احنا هنشوف بقيه الديفرنشال بقى يلا.
Yes. Now after reaching the entity axial spondyloarthritis, now in fact axial spondyloarthritis is not a single disease. This is an entity, and by saying that this is an entity, I mean that scientists have grouped some diseases, some in fact major diseases, and they group these diseases under this entity, under this wide umbrella. And the reason for this classification is that for this grouping is that these diseases that fall under this umbrella share the clinical feature. They also share some of the genetics, and they also share the underlying pathogenic mechanism. Now, what are these diseases that were grouped under this kind of unique umbrella named axial spondyloarthritis? These diseases are the psoriatic arthritis, the ankylosing spondylitis, reactive arthritis, enteropathic spondyloarthritis. And to be honest with you, there are two other diseases, juvenile spondyloarthritis and undifferentiated spondyloarthritis. But for the sake of simplicity, I've just decided to make this algorithm around the enteropath, around the previous 4 diseases. Now, to discriminate between these 4 diseases, we're going to ask a fundamental question. This fundamental question is in fact about the gastrointestinal tract, which is there a diarrhea? If the patient tells you that there is a diarrhea, then you should start directing your thinking about something that's related to the gastrointestinal tract, and you're gonna start an inquiry about some symptoms. Is there any history of GIT symptoms? Is there an associated rash, or is there a bloody with mucus diarrhea. And this is quite a very important and specific feature for Crohn's disease and ulcerative colitis. So IBDs, including Crohn's and ulcerative colitis, come with this presentation, bloody with mucus diarrhea. So if the history includes this thing here, bloody and mucus diarrhea, you should think of ulcerative colitis and Crohn's disease as the underlying causes for this axial spondyloarthritis. Now, if we have a history, then we're gonna go for the investigations. If the investigations reveal IDA, iron deficiency anemia, and thrombocytosis. Yes.
So by clinical feature, enteropathic arthritis is excluded. صح؟
Yes, in our case بالضبط الكيس بتاعتنا كانت excluded.
Okay. By clinical feature.
بالضبط كلام مظبوط بالضبط.
عشان بقيت الزملاء ياخدوا.
بالظبط يا دكتور. حضرتك كده بتحرق الموضوع، انا كنت سايبهم في الاخر بقى يعني هعرضهم الكيس.
لا عشان لا زي ما انت ماشي كده، زي ما انت ماشي كويس، عشان بس انا ببسط عليهم برضه.
بالظبط يا دكتور، كلام جميل. طيب now if we have an IDA, iron deficiency anemia, this also is a suggestive feature of an underlying bleeding, and we have the bleeding coming out with a stool. Then if you find these constellation of this kind of unique history and this kind of unique laboratory test, you should start thinking about enteropathic spondyloarthritis. Now I'm telling you that you should start thinking, you should start being suspicious about this entity. I'm not telling you that you're gonna diagnose this patient with this thing here, because if the patient is not diagnosed previously with ulcerative colitis or Crohn's disease, you cannot make this diagnosis just based on the history or the lab results. You need to go further for the endoscopy or colonoscopy to take a direct biopsy, either from the colon or from the gastrointestinal tract, to see to investigate this biopsy under the microscope to see whether there are the characteristic pathognomonic features for this disease or not. That was about the gastrointestinal. With regard to the relation to the arthritis part, we are going to ask a fundamental pivotal question here, which is this arthritis peripheral or not? If it's peripheral, then we need to investigate whether it's following the bowel flares or not. If it's following the bowel flare, then this is going to be a type 1 enteropathic spondyloarthritis. And this type 1 enteropathic spondyloarthritis usually comes in a form of oligo-asymmetric. And this is a quite important feature that I want you all to make. There is a connection between being oligo and asymmetric. A lot of diseases in medicine that come with oligoarthritis have also this asymmetric unique presentation. And here there is a funny thing that I like to make. This is type 1, and when you have a certain thing that's that's solo. One means solo, and solo is doing all things by his own. And when you have a solo, when you have an individual by his own, he should be independent. He should be only relying on himself to do the things that he needs, the things that has to be done. So this one here, this solo, you predict that this should be independent. This arthritis should be independent of any other features. But what's quite striking here is that this type 1 is dependent. We said that it follows the bowel flares. So the patient comes to you with, I have a pain in my gut, I have the pain in the tummy, and I have a pain that's also in my joint. And what's quite interesting that the pain in the joint follows the pain in my tummy, which is quite counterintuitive, because as I've just elaborated, the one is solo. Solo should be independent, but this arthritis is not independent. It's totally dependent on the bowel flares to elicit the symptoms. Now, what if this arthritis, this peripheral arthritis, does not follow the bowel flares? Then if it's not following the bowel flares, you should think of type 2, which is polyarticular and symmetrical. And as I've just said with type 1, this is oligo-asymmetric. This should be poly and symmetrical. A lot of diseases in medicine that have a polyarticular presentation comes in a symmetrical fashion. That was about the peripheral. We said if it's dependent, we're going to laugh, because if it's dependent, it shouldn't be solo. But here we have a solo who is dependent. It's not independent. And type 2 is the one who is in fact independent of the bowel flares. And if it's not in the peripheral arthritis, in fact, this is the patient comes to you with an axial arthritis affecting the spinal column, affecting the joints we have here, or even the hips or the shoulder roots. And this patient is going to be diagnosed with type 3 intrahepatic spondyloarthritis, axial spondylitis. That was the first thing we have. The second thing we have in patients coming to you with gastrointestinal symptoms, bloody and mucus rash, is to think of reactive arthritis. Now, what's basically reactive arthritis? Reactive arthritis is a disease that was previously known as Rhetus syndrome. Now, this Rhetus syndrome is a disease that represents an immunological cross reaction. And what I mean by immunological cross reaction is that you have an antigen, this is a unique antigen here, and you have an antibody, and this antibody is directed to this antigen. And you have, let's say that this antigen you have here is in fact a one that's foreign. It's not from your own vicinity. It's coming from the outside world. And what's quite interesting is that in your body, you have another antigen that's quite similar, and this is your own tissue. So يا دكتور حضرتك هتقول حاجه ولا؟ Okay, what I was trying to say here is that the underlying pathogenesis behind Rhetus syndrome reactive arthritis is immunological cross reaction. Immunological cross reaction means that your immune system, represented by the antibodies, is in fact mixing between the foreign bodies, invading your own system and your own tissue. And this now in this case, in this immunological cross reaction, your immune tissues, your own tissues are being invaded and affected by the antibodies. This is basically what's happening here in reactive arthritis. The patient comes to you with a history of gastrointestinal infection or genitourinary infection. Usually the causative agents are Yersinia, shigellosis, Campylobacter, Neisseria gonorrhea, Chlamydia trachomatis, or Ureaplasma ureaticum. What's quite unique about this disease here, as it's in fact it's a reactive arthritis. It's an arthritis. It's an antibody that's directed towards your joints. In a way, your joints. I can't write the list of this word here. Antibodies directed to your joint.
Sorry. Active arthritis preceded by infection of gastrointestinal or genitourinary tract.
بالظبط.
اوكي؟
بالظبط. لازم يكون في انفكشن الجاستروintestinal tract والجينيتورينري.
عشان نميك الاكسكلوجن to gastrointestinal or genitourinary infection. اي اورجانيزم بقى كلاميديا بيعمل الانفكشن ده، بس هي preceded by infection. اوكي؟
بالظبط يا دكتور احمد.
Okay.
With this disease, there are usually some particular extra-articular manifestations: urethritis, balanitis, aphthostomatitis, and keratoderma xenorrhagicum, which is a unique dermatological change in your hands or your foot. I'm saying that this is a reactive arthritis, and I didn't say that this is a septic one. So if you did a joint aspiration, that fluid is going to be crystal clear. And if you did a culture, the culture will be negative because it's not septic. You do not have an organism in your joint. You basically have a crazy immunoglobulins that's somehow affecting and damaging, doing in fact a massive destruction mission for your joint instead of destroying the foreign antibody in your system, invading your body. Now, that was basically if we have that history of gastrointestinal or bloody diarrhea. But what if this history was absent and our patient was complaining of malabsorption and severe weight loss? And we can see here that malabsorption, weight loss, migratory polyarticular arthritis with large joint involvement, in a patient with unexplained arthritis. This raises the possibility of having a Whipple's disease. And to make the definitive diagnosis of Whipple's disease, you need to go there inside the gastrointestinal tract to come up with a jejunal biopsy that's gonna show a foamy macrophages with pass positive stain, or instead of going inside the gastrointestinal tract and taking a specimen from the small bowel, you could also reach for the lymph node or the joint affected to take either a synovial tissue or a synovial fluid. And this fluid, and from this fluid, you're gonna do the PCR test on to detect this organism, which in fact this Whipple's disease is a disease that's elicited by a gram-positive organism, and you're going to look for that organism in the PCR from specimens from the tissue, fluid, or small bowel. And if you're very alert here, I didn't say blood, because usually the blood sample is not that effective for the PCR testing for this Whipple's disease. Now that was for the diarrhea. What if the patient has no diarrhea? The patient is not complaining of diarrhea, but and he's coming to you with a unilateral asymmetric arthritis and atypical syndromyophytes that are associated with nail dystrophies in a form of oncolysis, nail pitting, oil spotting, and ledging. Now let's understand this nail dystrophies here. Oncolysis, this part lysis means loosening, okay, and onco means nail. So basically, nail dystrophies is that you have a nail that's loosened. If this is here, you know, like this is your digit, and here you have this kind of nail, and if this nail is separated from the underlying hyponychium, this condition is known as oncolysis. The hyponychium is this dermal lining here, this keratoderms at the distal part of your digit. When your nail starts to separate from this area, this condition is known as oncolysis. And when you have something that's separated, you know, it's quite interesting to stop there for a moment and say, aha, I want to look further at this thing here to see what are the unique features it has. And one of the unique features it has is you're going to see some ridges. These are ridges. You're going to see a nail with ridges. In some patients, you're going to see a nail with pitting. And by pitting, I mean pits, defects, spot line defects in the nail. And in other patients, you may find oil spotting. And by oil spotting, this is spots that are there in your nail that have this yellow. This is the yellow. They have yellow and red spots and pigmentations. Another feature is psoriatic lesion. Now, a very important feature here is that I have listed the nail dystrophy superior to the psoriatic lesion in this entity, which is frankly the psoriatic arthritis. And the reason behind that is that if you find a patient with nail dystrophy, you can say that this patient is having psoriatic arthritis with high specificity and sensitivity, which is in fact not the case with the psoriatic lesion. Okay, which is in fact not the case with the psoriatic lesion, because some patients may come with arthritis. Here is the joint infection. Yes, نعم دكتور.
So what supported diagnosis? What supported diagnosis of psoriatic arthritis in our case?
Yeah, إن هم عنده nail dystrophies. كان عندها نيل بيتنج، تمام، وكان عندها سورياتيك ليجن موجوده على ال
اهم حاجه سورياتيك ليجن موجوده، تمام. وايه تاني؟
هو دكتور احنا كنت حابب اخلي الجزء ده في الاخر بحيث ان احنا يعني نقوله كلنا مع بعض بعد ما نخلص، وده كان ابروتش عام لكل العيانين اللي عندهم القصه دي. فهل حضرتك تحب نكمل كده ولا؟
بس لا كمل زي ما انت كده، بس عشان انا نوضح لبقيه الزملاء عشان ما يتلخبطوش، بس عشان يبقوا فاهمين برضو هم معانا. وكده هتقولها انت امبريف في الاخر.
اوكي تمام دكتور. هو هنا زي ما حضرتك قلت بالظبط، يعني الفكره ان هو العيانه كان عندها نيل بيتنج، وكان عندها سورياتيك ليجن موجوده على الميتاكاربال جوينتس وعلى الديستال وعلى اجاس كانت ديستال انترفينجل جوينتس كانت موجوده. فده كان بيفيفر القصه دي. وبرضه الاتيبيكال سندس مايوفايتس اللي كانت موجوده في الاكس راي هي حاجه يونيك للموضوع.
Excellent.
Yes. I was talking about the psoriatic lesion, and what's quite interesting about the psoriatic lesion is that it's not usually frank. Sometimes you need to dig deeper to find that psoriatic lesion. Sometimes you need to check for the nape of the neck. Sometimes you need to investigate the scalp thoroughly. Sometimes you need to investigate the umbilicus. Sometimes you need to check for the gluteal cleft, or the natal cleft. Sometimes you need to investigate the extensor surfaces of the arms or the leg for one. And what I'm writing here is like father, like son, because I imagine this psoriatic arthritis as the father, and I imagine the manifestations of this disease as his progeny. And not always, not every circumstance you're going to meet the father with all his sons. So in some psoriatic arthritis, this psoriatic lesion could in fact precede the arthritis event. The patient may come to you with arthritis at this. Okay, this is the timeline we have. This is the 0, and this is the time the presentation. The patient is coming to you here with arthritis. And this arthritis is the whole thing that he is complaining about. If you didn't ask the patient about the history carefully, you may miss here an episode of psoriatic lesion that appeared insidiously in the scalp and eventually disappeared. So it's quite tricky. You have to investigate the history thoroughly to reach to exclude the possibility of having a previous psoriatic arthritis. Now, this disease, the psoriatic arthritis, may come with 4 major patterns. Now, these 4 major patterns are quite unique, and they're very, very important, and you have to get insight into them. The first pattern here is distal interphalangeal joint, was quite the most common. You say psoriatic arthritis, and it comes to you directly that this is one of the entities like osteoarthritis that affects the distal interphalangeal joint. And this affection usually comes with dactylitis or sausage digit. Sausage digit, and that's the reason behind this sausage is that you remember the enthesitis we've talked about. This disease is so severe, it doesn't only affect the joint, it also affects the tendons inserted around that joint. So the joint is inflamed, you have a distal interphalangeal joint affection, but also the tendons inserted around that joint are also inflamed in a form of enthesitis that's presenting with a sausage digit. And since we're talking about distal, it's quite intuitive that the next pattern could be a proximal one. And what's quite interesting about this proximal one is that it comes in a polyarticular. You remember we said that a lot of diseases in medicine that come in a polyarticular fashion comes also with a symmetrical, like here, polyarticular symmetrical, and a lot of diseases that come with oligo are asymmetric. Here, this proximal entity usually comes in a form of polyarticular and symmetric. And a famous disease in rheumatology that comes also with this presentation is rheumatoid arthritis. So it's quite fuzzy here to differentiate between rheumatoid arthritis and psoriatic arthritis. It really needs a professional to discriminate between them. Now, that was the 2 first entities, or the 2 first patterns. Now, I have just said that this disease may come in a polyarticular symmetric, and also it could come in an oligo asymmetric. It had the thing in its opposite. This is a quite interesting disease. Polyarticular, symmetric, oligoarticular, and asymmetric. This is another pattern for psoriatic arthritis. And this pattern usually affects the hips and knees. So we have basically the first 3. We have the distal interphalangeal joint, the famous one. Distal, remember that there could be the next pattern could be a proximal, and I've told you that this proximal usually comes in a polyarticular symmetric that resembles rheumatoid arthritis, and this is quite difficult to reach a diagnosis in these patients. And from this one, polyarticular symmetric, if this disease comes in a polyarticular symmetric, and you know that this disease has some patterns, then the next pattern could be oligoarticular and asymmetric, and this oligoarticular and asymmetric affects the hip and knees. And I want you to know that psoriatic arthritis is a very aggressive disease. That may lead to a very unique pattern of arthritis mutilans. Mutilans means injury. arthritis joint. So this is a variant that's going to injure your joint severely, leading to a deformity known as pencil and cup appearance in the X-ray. That was about the clinical presentation, and these were the 4 major patterns we have. Distal interpharyngeal.
علاء يعني نهاري بحبه عشان الوقت خلاص كده.
خلاص احنا بس احنا قدامنا الانكيلوزنج سبونديلايتس
يعني تحضيرها اكسترا عشان دكتور مؤمن وراه البرزنتيشن بتاعته بعد كده وعنده محاضره هيشرحها برضه نفس الكلام. فانت اكسلنت برزنتيشن يعني فيري اكسلنت.
اوكي حضرتك اديني 12 دقيقه بالظبط واخلص من المحاضره ان شاء الله. اوكي
طيب يعني
اوكي. That was about the clinical presentation for the psoriatic arthritis. The lab investigations are going to show mild elevated ESR CRP, and I want to stress here in the mild or even normal ESR, because ESR and CRP, although this is an inflammatory process, is not as well associated with psoriatic arthritis like other inflammatory processes. We could also see here elevated uric acid, and we can see an inflammatory synovial joint, synovial fluid. With regard to the imaging, as I've just elaborated in the previous algorithm, we usually like to start the investigations with MRI, because this MRI is very much helpful in showing the inflammation in soft tissues like dactylitis, enthesitis, and the early peripheral arthritis, and also in axial or sacroiliac inflammations. Later on in the disease, as the disease progresses, you could order an X-ray, and this X-ray is going to show you the unique deformity for this disease, pencil and cup appearance, sacroiliac sclerosis, or atypical syndesmyophytes. That was about the psoriatic arthritis. Now, the last entity we have today is ankylosing spondylitis, and basically, itis means inflammation, spondylo means vertebra, and ankylosing means fusion. So basically, this is a disease that's causing your vertebra to fuse. This affection is usually manifested in an ascending axial spondylitis. This could be accompanied with a transient or persistent peripheral arthritis. The patient may come to you complaining of radiation to buttocks, flattened lumbar lordosis, Look, this patient comes to you with this thing here. This is a question mark. One of the symbols I do love a lot in this life. This is a flattened lumbar lordosis. Here we have an exaggerated lumbar kyphosis. Okay, and here we have an extended neck. Okay, in addition, this patient may have a protuberant abdomen. And there is a test known as positive Chopper's test, and I guess I don't have time to elaborate this test. With regard to the imaging studies, for the first 2 years, MRI is going to be a lot of going to be what I'm trying to say is that it's going to be invaluable. MRI could show you the inflammatory areas in your sacroiliac joint or vertebra that may be shiny or edematous. And later on, as the disease proceeds, the spine is severely affected. They call this condition bamboo spine. Well, speaking about this condition, and as a deeply patriotic Egyptian, I prefer to call it sugarcane spine. Well, basically, that was the algorithm we have today, and that's the bamboo, and that's the sugar cane, known in Egypt as asab sukkar. I guess they are the same. No, but this is one with this is the one speaking from Singapore, and this is one speaking from Egypt.